Welcome to the Cambridge Health Alliance Health is Wealth. My name is Roberta Robinson. I'm Director of Marketing and Outreach for the Geriatric Division of the Cambridge Health Alliance. And today we have with us Dr. Alex White. And Dr. White is Chief of Pulmonary Critical Care and Sleep Medicine. Did I get that right?
That is correct.
I got it right. So thank you so much for coming on board, because Dr. White is going to be talking about lungs and how that maybe even affects the sleep for us. So Dr. White, this is a hot topic for our people out here, as you might well already know, I'm sure. What are the most common diagnoses that you see in your office, in the clinic? He has a clinic.
We have 3 clinics, and we have clinics located in Cambridge, in Somerville and in Everett, and we have 5 doctors who work, and we see a range of patients. We see patients with chronic obstructive lung disease, which is a smoking related lung disease. We have patients with...
Is that strictly smoking related?
Mainly, predominantly smoking related. Wow. Sometimes people who inhale smoke from cooking purposes, people who've immigrated here from other countries who have cooked on open fires can develop some COPD.
Really?
Yeah.
So, you're right, COPD is...
But it's mainly smoking related.
Wow, I never knew that. I mean, I knew smoking was a cause, but I didn't know it was mainly. This is why we do the show. We find out so many things here.
We see patients with asthma.
Right.
We see patients with what we call nodules or shadows on the lung. We find those on a CAT scan of the lung, and we have to determine the next steps in their care. We see patients with lung cancer, unfortunately, who have, most of them smokers, some of them non-smokers. And then we see patients with a variety of sleep disorders, as I told you, mainly obstructive sleep apnea. Mm.
So with the, let's start with, I guess, and maybe some CHF, the congestive heart failure.
Yes, congestive heart failure, because both the heart and the lungs can be affected by smoking. So patients can actually present with both diagnoses, and you're trying to figure out, is the shortness of breath due to the lung disease, or is it due to the heart disease, or a combination of both. So we work closely with our cardiology department at Cambridge Health Alliance on those patients. Mm.
I was going to ask you that question, so you were ahead of me on that. Now, of all the things you mentioned, is there one that's more prevalent than others?
COPD is probably one of the most prevalent diagnoses that we deal with at Cambridge Health Alliance.
So now maybe someone smoked, maybe they no longer smoke.
Correct.
And they've developed COPD, and they're usually, as they get older? As they get older, they develop it?
It depends on a number of things. It depends on the amount that they smoke, but it also depends on their genetic makeup and on their likelihood to develop COPD. We know that it's the interaction between the inhaling the cigarettes and the makeup of the person's genes that probably drives the creation of the COPD. So for some people it may happen in a number of years, 5 or 6 or 7 years. For others it may happen over a much longer period of time. So it really depends.
And so if someone, what's the average age that someone comes to you with COPD?
They're usually in their 40s or 50s typically.
Really? That young?
Yeah, sometimes a little older. But typically patients may have a chronic cough or some shortness of breath that they're attributing to being a little out of shape. And then when we do breathing tests and chest x-rays and CAT scans, we're able to figure out that they actually have some lung disease related to their cigarette smoking.
Now, and can you at that time somehow look at their genetic makeup and well, they've already got the COPD at that point, so it's a mood issue.
It's a mood issue. What we're that will be part of research studies that are going on at the moment. But when we see patients, we are merely trying to, not merely, but we are diagnosing them. And unfortunately, their genetic makeup is of less importance right now, but it may be important in the future in terms of treatment. It may be that people with certain genetic makeup may be more amenable to certain types of treatment.
So what are some of the treatments for COPD?
The major treatments revolve around inhalers, which are drugs that are contained in aerosols that the patient can
Same that you would
inhale.
use for asthma, is that right?
Very similar drugs. And there are drugs that work quickly, acutely if you're having a problem, and then there are drugs that we use to prevent getting a problem. So there's different types of inhalers, and we go over the different types of inhalers with the patients, and we decide which regimen of inhalers the patient needs based on their various on their severity of their chronic obstructive lung disease.
Now, I happen to have a lot of asthmatics in my family, and 4 of them were my children, and 1 was my mother. And I had to give them nebulizer treatments,
Yes.
which is a machine that you use that gives them, it's a breathing treatment for them.
Correct.
Now, so would something like that also be recommended for COPD?
For some patients, a nebulizer treatment works well because they have trouble using the inhaler. They're not able to manipulate it because they might have some arthritis in their hands or stiffness in their hands. For those patients, you might sit them in front of a nebulizer machine and then they just sit and breathe the medication. And that can be very useful for patients, especially some of our older patients.
So, there's a lot to it, isn't there? And breathing is not overrated.
Breathing is not overrated, no. So we make sure the patient is on the right regimen of drugs. We check and see whether or not they need oxygen.
Yeah.
And sometimes the patients are sick and they need to be admitted to the hospital for a flare of their chronic obstructive lung disease. And they may need antibiotics, intravenous treatment for a few days, and then we get them home again.
Now I'm going to ask you this question: of those patients, some of them, it's mainly a smoking-related disease,
Mainly.
and people come to you in their 40s, 50s, 60s, and older. And are they still smoking? Many of them.
Some of them are, unfortunately.
Yeah.
Some are still smoking because it can be very difficult to quit smoking cigarettes.
Right.
There's both a psychological and a physical addiction to it. At Cambridge Health Alliance, we have a quit line that they can call, and we have medications we can give, like nicotine patches, nicotine gum, nicotine inhalers. There's medicine called Chantix you can give for some patients. So there's a variety of options to help patients quit, but the best way to quit is to be motivated to quit and to set a quit date and to try and remain engaged with that process. And it's very difficult for some patients. They're heavily addicted to nicotine, smoked for many years.
I know, and a lot of people feel that they're so nervous. It's kind of like their crutch. It's become their crutch, but actually the nicotine aids in that stressful feeling, doesn't it?
It can do, and for some of our patients who have some anxiety or some depression or other psychiatric issues, it can be particularly difficult for them because they find smoking cigarettes is actually, as you say, it helps them. But unfortunately, that help comes at a price sometimes, and you can develop lung disease that can be a problem.
Right. And
COPD.
is there any cure for that? Or if once you get that COPD, is it yours forever?
It is. Unfortunately,
forever.
it is. Some of it can be reversed. The sort of acute bronchitis, the acute infectious part of it, but once the lung becomes sufficiently damaged, you can't reverse that. And in extreme cases, for the appropriately aged patient, they may do lung transplantation for somebody with COPD, but that would be not that common.
Yeah.
But yes, once you develop the disease, it cannot be reversed, which is important for patients to understand. They sometimes think that when they quit smoking, everything will get better. It doesn't.
No. Can you hold the progression?
You can. If you quit smoking, you can delay you go back to a normal progression of lung deterioration. Unfortunately for all of us, as we age, our lungs get a little bit smaller and a little less elastic. And for patients who smoke and then quit, their deterioration goes more to the normal, which is unfortunate for all of us, but at least when you quit smoking, you go back onto a more normal track. But you're starting out maybe with lungs that are, damaged, and so you don't have as much reserve. And as I tell my patients, you're basically using your reserve tank when you're smoking, and you need that reserve tank for exercise and for when you get sick. And when you don't have that, it can get you into trouble.
It's so unfortunate that we don't realize this earlier. Unfortunately, we can talk about it and talk about it and talk about it, but what I found is we're a need-driven business.
Yeah.
And people don't really
pay much attention until they need to, and then they're in trouble.
But we're doing better. I mean, 50 years ago, a much higher percentage of the population smoked. And in Massachusetts now, it's somewhere between 15 and 18%. So we've done much better with getting people not to start smoking.
That's good.
We're definitely on a better track, but
That's good.
we just need to get rid of it.
Yeah, that's encouraging. Okay, so let's see. We have so let's talk about the nodules and the lung cancer, because that is near and dear to my heart right now. I have a friend that's been going through that, and she actually was in a car accident and woke up one morning, thought she was having a heart attack. So she went to called the ambulance, got to the hospital, and they found the nodules on her lung, which turned out to be cancerous. Had the operation, removed the lower lobe of the lung, and then took a plane trip to Florida, and the lung collapsed on her, and then it separated from the chest cavity. So it's been a very long, and this woman was the picture of health, the picture of health, and she managed her stress. It just doesn't matter sometimes. That you can do all of the right things and still end up with some of these things. That's true.
You can, and lung nodules can occur in people who don't smoke. And unfortunately, some of those nodules can be lung cancer, even though you never smoked.
Would it be from secondhand smoke? Would that?
Possibly. Secondhand smoke is more attributed to COPD or asthma type symptoms rather than lung cancer, but there probably is a small number of patients who develop it from heavy exposure to secondhand smoke. But we find nodules on CAT scans now. We have the Medicare and Medicaid have approved screening CAT scans, which we do for patients who are smokers between the ages of 55 and 80. So we can screen people and find nodules and then follow them and decide if they need surgery or not. But it sounds as though your friend, the nodule was picked up on a scan done for other reasons, maybe.
Incidental finding. Isn't that amazing?
We see a lot of those. We see a lot of that in Cambridge Health Alliance, and we have a program designed to, manage that population of patients who have incidental nodules. Because when you find a nodule, you don't know whether it's a cancer or whether it's just a small scar or a small lymph node that has been in the lung for some time. So what we do is we follow it on subsequent scans. So you might scan it in 3 months or in 6 months, depending on if the patient is a smoker or not. If you're a smoker, we are more worried that it might be a lung cancer. If you're a non-smoker, we're a little less worried. So depending on which category you fall into, we will get a scan after 3 months or 6 months or 9 months or a year, and then follow it. And if it's not changing over time, the chances of it being a cancer are very, very small.
And you just live with them?
And we usually, after 2 years of scanning, we will say there's no need to scan it anymore.
So is there a way, do they do biopsies on that?
Yes.
Oh, they do?
Yeah. If we have a nodule that is increasing in size and we're concerned about it, we do a special CAT scan called a PET scan, where we can inject a sort of dye that will light up if it's a malignant tumor. And then it may be that you will need to put a needle into this to figure out what it is, and that will be done using our radiology department. They have an interventional radiology department at Cambridge Health Alliance, and they're very skilled people who will put a needle into a smallish nodule, and then that goes to pathology, and the pathologists look at it.
They withdraw some fluids and then send that?
They put that on a slide and they show it to the pathologist, and they take a look at it and decide whether it's cancer or not. And then you might make a decision to either leave it and watch it, or you may decide to remove it. And we have a thoracic surgeon, Dr. Wilson, who works with us at Cambridge Health Alliance, and she would do the surgery.
Sure.
Yeah.
All right, so, and it's a scary thing, isn't it?
I think anytime people hear the word nodule or cancer in the lung, they do worry, because there's a lot of stuff out there about how it's difficult to treat. So the emphasis now is trying to pick it up early, because if you pick it up early, you can remove it early, and that's your best chance of cure.
Right, and that's true of everything. That's true of everything. So we must always follow up and follow through. So anything that might be brewing in our bodies, the earlier we get it, the better off we are.
That's true.
So let's see, what have we got left to talk about? We have the,
We have patients with asthma,
asthma.
which is managed in a similar way to COPD in that we deal with inhalers. We have inhaled medications that we would use, and we educate patients in how to use their inhalers, and we teach them how to measure their own breathing at home using a peak flow meter. And then
Is that one of those things you breathe into?
you breathe into, and a little thing that goes up and it
Yeah.
tells you how well you're doing, and that can help the patient manage their asthma. And they learn when to come to the hospital, when they need to come, whether they need to start on some emergency treatment at home. So asthma is another group of diseases that we would deal with, and that tends to be in the younger population.
Now, I have experience with asthma because I had 4 kids with asthma, and I found it to be a highly emotional disease. In other words, they started with it very young, a couple of them. One only got it when he got a cold, but a couple of my kids started very young. And my oldest boy, as a matter of fact, was in anticipation of the holiday of Christmas and even Easter. He would inevitably be on the couch.
Yeah.
Because he'd work himself right up and he couldn't even enjoy the holiday. So
Yes.
would you say that it is a highly emotional disease?
I would say that anxiety is known to sometimes precipitate a state that can, make the patient's asthma worse. So learning to manage anxious situations and learning how to do that is a component of managing asthma. So there are triggers for asthma. Anxiety is one of them. Cold air might be another one. The 14 cats you have in your house might be another one.
They are
dander.
allergic. Asthmatics are usually allergic to a lot of different things, aren't they?
Some of them are, yeah. Some of them it's not so obvious what they're allergic to, but some are allergic to a lot of things in the environment. Pollens, grasses, pets, dander,
Dust, mold,
birds,
mildew.
whatever. Dust, mildew, all that stuff, yeah. So identifying those triggers and trying to avoid them, and then learning to manage anxiety, which necessarily comes along with not only in asthmatic patients, but also with COPD patients get anxious. And one of the strategies we are developing at Cambridge Health Alliance, just to switch back to COPD for a second, is that we're putting in an outpatient pulmonary rehabilitation centre, where patients will come for sessions 2 or 3 days a week, like going to a gym. And one of the components of that will be to help patients deal with their anxieties about their breathing and teach them strategies to deal with that. That's going to start in March.
And what campus?
It's going to start in Everett because we have a large population of COPD patients at Everett. So that's where we're going to start.
At the Everett Hospital.
Yes.
I just want to clarify that there's been no change except for the name of the.
Correct.
It was the Whidden Hospital, and now it's Cambridge Health Alliance Everett Hospital, and that's just because we had the Somerville Hospital, the Cambridge Hospital, and now we have the Everett Hospital.
Right.
Which makes perfect sense because I would say Whidden and people wouldn't know where it was.
Right.
Now we know it's in Everett. So we'll start at the Everett.
It'll start there, but in the future we can look again and see if it's appropriate to start something more locally here in Cambridge and in Somerville. But we're going to take it one step at a time.
Right. And the environment with the the pollution and toxic fumes and things of that nature. What about the foods? Does that foods? I guess if they're allergic, it might play a role, but
Yeah, some people have food allergies, but that would tend generally not to manifest itself as lung disease.
it wouldn't trigger an asthma attack.
Usually asthma is triggered by inhaled compounds, things you are breathing in. It could be the odor of certain foods, it could be the odor of certain perfumes, but it's more what's in the air that will trigger an asthmatic attack. There are certain foods that you can eat if you're very allergic to them that can cause problems with the airway.
Right.
Usually it's called angioedema. People may be allergic to shellfish or certain medications. That will be a sort of more common route that you might end up with breathing problems.
Exactly. Right. My daughter, if she would have a nut, then her airways close up. Close up. That's it.
And that can be very frightening.
It can be frightening. It can also be life-threatening
It can be life-threatening too.
if she doesn't get treatment right away.
Correct.
So, is there anything else with respect to the lung, or should we do a quick segue? We have a few more minutes into how the lung disease affects the sleep.
Sure. So we as lung doctors, some of us also practice sleep medicine. And when we sleep, if we have trouble with our breathing, it can be a problem. So patients with COPD, for example, sometimes when they sleep, their oxygen level may go down and they may need some supplemental oxygen at night. Need to make sure that they're taking their inhalers correctly so they don't get a flare of their COPD at night. But the one thing that we have a lot of is obstructive sleep apnea, which can occur in a range of populations, usually is associated with excessive weight. And that can occur in any population of patients. But when you have a patient with COPD who maybe is overweight, they may also have obstructive sleep apnea. And then they have a problem when they're sleeping at night, in that they have snoring at night. Their spouse or somebody they sleep with may see that they're not breathing periodically, that they're waking up and gasping. And then as a result of that disturbed sleep, they may be dozing off during the day, they may not be able to function at work, they may not be able to concentrate, they may be falling asleep driving their car. So there's a lot of possible complications from that. So when patients have those complaints, we do sleep studies on them. Some of them are done at home, and some of them are done in Somerville Hospital, where we have our 4-bed sleep lab at Cambridge Health Alliance.
I never knew we had a sleep lab.
We do.
Look at that.
Yes.
Wow. That's why we do the show.
Yes.
So how is it done at home? They have a monitor? Or
Yes, it's very simple. The patient is giving a very simple monitor. It's about the size of a cell phone. And then they have a variety of connections. They connect something in their nose, something on their finger, a belt around their chest. They push a button on the device before they go to sleep, and it will record. And then they push a button again in the morning, and then they bring it back to us. And we can download that onto the computer and take a look at it. Works very well for people who have easy to diagnose sleep apnea. More difficult to diagnose sleep apnea sometimes requires an in-lab test.
So if you mentioned being overweight, and if someone loses some weight, would that sometimes change the breathing? I would think there'd be less pressure on your airway and even your chest, your lungs. Would that help to restore the breathing?
Absolutely, it may. I mean, there are a percentage of patients who, for example, some patients who are very overweight go through weight loss surgery. And after that, sometimes their sleep apnea is completely eliminated.
Wow.
And as long as they keep the weight off, their upper airway is normal, their abdomen is not distended, so their breathing at night is fine. It's hard for people to lose weight, and certainly it's very hard to lose enough weight that you will eliminate the sleep apnea, but sometimes it's possible.
Is there a certain amount that would if you lost 25 pounds, if you lost 50 pounds, or would that matter what your weight was in the first place?
I think it needs to be individualized. I think for some people losing 10 or 15 pounds might be enough. For others, depending on how overweight they are, they may need to lose 100 pounds, 150 pounds. So it really depends on the individual patient and where the weight is deposited, whether it's on your neck, on your chest, in your abdomen. And people will deposit weight in different places depending on their form of obesity. So sleep apnea is one of the more common sleep disorders that we deal with.
Right, and we know that we have this mask, right? This CPAP,
the CPAP mask, yes.
CPAP mask. And some people, I've heard, have difficulty with that. They can't, although you mentioned earlier that you could sleep on your side with that. I think the people that have expressed discomfort to me, they felt that they had to just sleep on their backs, and that was difficult for them.
You can sleep on your side with a CPAP machine, absolutely. And it's important to make sure that the mask you have is fitted correctly for you, that it's the right shape, that the straps aren't too tight, and that the air coming in is humidified and heated. And the machines are better now than they were. They're quieter, the tubing is heated, the humidifiers work well. It's not perfect, but for the majority of people who have clinically significant sleep apnea, we're able to get them to use the device for 5 or 6 hours a night, which is enough to treat the sleep apnea and prevent daytime sleepiness, high blood pressure, etc.
So that's an important point. You're making me think that you could never lend someone else a machine because of all the proper fit. I'm sure it happens out here.
Oh, no doubt. Yes.
But everything is so individualized that it has to be fit properly to you.
Ideally, yes,
Right.
ideally.
All right, so that you would have a better chance of success.
That's
Which
right.
makes sense.
That's right.
Right?
That's right.
So, let's see. To get to you, it must be a referral from a primary healthcare provider. Is that
Typically,
correct?
yes, me or my colleagues, yes.
Yes. So for this, the pulmonary or the sleep problems, it would be a referral from the primary care. And believe it or not, I am still finding people out here that do not have a primary healthcare provider, if you can believe it. But it's true. And so I just want to just do a quick little commercial because the Cambridge Health Alliance, you've mentioned so many things that the Cambridge Health Alliance has. And you know, it always amazes me because we're looked at and viewed as a small community hospital, which we are a small community hospital, but we have so many things to offer. I mean, we're an accredited breast cancer center. It goes on, the things that we do, which always amaze me. I always find out something new, and I've been here for 10 years. But I wanted to just let the folks know that if you cannot communicate well with your primary care provider or you do not have one, the Cambridge Health Alliance has a doctor finder service, and the number is 617-665-1305. They will not only help you assign you a new doctor, but they'll make your first appointment for you. And that's a way to get to Dr. White and his colleagues if you're having any of these issues.
Absolutely.
And nothing should be overlooked. If you're having any discomfort, I would say, wouldn't you say as a doctor, that we need to check it out. They feel that they're bothering people, but I think it's always better to check it out, don't you agree?
Absolutely, and for the lungs, it's usually a persistent cough or chest pain, shortness of breath that isn't going away, that is getting worse. Coughing up any blood is obviously always a worrying symptom. Weight loss, so those would be symptoms of lung disease that we really need to pay attention to. But certainly, a lot of our patients come because they have a cough that just didn't go away.
So, well, we're out of time, but thank you so much for coming on board. It always amazes me how much information we get across in just 1/2 hour. Thank you so much, Dr. White.
You're very welcome. Thank you.
And we will see you next time.